Unfortunately, there was not a single non-invasive cancer, and this goes back to what we were talking about with the calcifications. When we do a mammogram, no matter how dense breasted your breast is, if you see calcifications, the most likely cancer that you'll find is the ductal carcinoma in situ, which cannot spread anyplace else. And the importance of that is we don't think you should be doing screening ultrasound in a vacuum. You should continue to do mammography. In these cases, they were all contained within the breast except for one which had gone to the lymph nodes. About 10% of these women did require biopsies. Another 10% had to come back in 6 months. And about 10% had positive biopsy. And what that goes back to is that positive predictive value. If you have an abnormal ultrasound, how often will you get it? Again, typically, and the recommendation based upon this of the American College of Radiology was that it was too low a rate to consider it as a routine, but it should be considered in some higher risk women with dense breasts. What our philosophy has always been, and my philosophy is if you're going to a radiologist who is very good at doing screening ultrasounds, that you should continue because they know what they're looking for. Tom Kolb, it takes about 2 minutes to do each breast. I sometimes get lists from outside facilities that have 20 things marked in each breast. That's not helping anyone. If you talk about anxiety, that helps it, and it's rare. And if we looked at their rate of finding cancer, it's probably, less than 1%. So you really need to go to someone who knows what they're doing. And so that's the bottom line with screening ultrasound. So our current recommendations there are no formal recommendations. There's no group who has come out and said anything. And in fact, the American College of Radiology just put out another statement saying we're not going to make a recommendation one way or another. I think women with dense breast tissue should consider it. And certainly, as I said, it should be done at a facility where this is done regularly. And the hope is that we'll continue to gather data on it. So turning now to screening for the high-risk patient. If we're saying we looked at this ultrasound, oh yeah. Yeah.
What about nursing mothers?
It's a good question. Right. It can be very extended. And the feeling is you can get mammography, but it is not extremely helpful because of the milk making it very difficult to see anything. So again, there are radiologists who can differentiate milk in the ducts from other lesions, and so it's reasonable to go doing that. What I typically do with the higher risk women during nursing, even during pregnancy, I have them come in every 3 months rather than every 6 months for exams because you will feel things on exam and then you can target it a little bit more too. So we do still use ultrasound sometimes in there, but mammography is not that helpful during that period of time. So now when we look at the risk factors that are associated with breast cancer, age is right at the top, and that's important to keep in mind. Reproductive factors, do you have a child late in life? Hormones that are taken, obviously hormone replacement therapy, body weight and physical activity. Alcohol has gotten a lot of press lately, diet, radiation exposure. And when we talk about radiation exposure, we're mainly talking about women who've had lymphomas at young age, and they get what's called mantle radiation, where it's across their chest. And finally, family history. When you look at all of these together, age and family history are really the most important risk factors. There are a number of other things that come into play, but these two things are really important. So when we look at that, if you take the general population and look at the age-specific probability of getting breast cancer, so if you're 20, within 10 years, you have a 0.05% chance of developing breast cancer. Even between 30 and 40, there's only less than a 0.5% chance, and it doesn't go up significantly till about 50 and above. So that's one of the reasons that the task force said we can start at 50, but already you see a big jump between 30 and 40, which is why the groups have really said we need to look at this group from 40 to 50. But if you take a population of women who carries what's called a BRCA mutation. So again, these are mutations in the genes that are coded when you're born. There's nothing you can do to change this. And you compare it in the light blue, those are women who don't carry the BRCA mutation, and that's their risk over a period of time. It gets as high as 12%, as we talked about. But if you look at a woman who carries a mutation, it can be as high as 60 to even some families, it's 80%. So this is truly a group that we want to key in on. How do we look at how do we find cancers at an early point in time? Some of the other mutations that are associated with breast cancer are listed here. I bring it up only because when we send someone for genetic counseling, it's really important to know, yes, 80% are from the BRCA1 and 2, but there are other things that you go for. So a lot of gynecologists are now sending off BRCA1 and BRCA2 testing, which I think is great, because I think if you want the information, it's a good starting place. But you have to keep in mind that if you have a strong family history, you may still want to go and see a true genetic counselor as opposed to just getting the test through your gynecologist, because you could have something else. Continuing. So what is the problem in this group? Well, as you saw, there's a huge incidence of breast cancer, a higher incidence, not a huge, but a higher incidence in women who are younger. And the problem is, again, I'm sorry these don't project a little better, but in a fatty breast, it's very easy to see what is going on in there. In the middle is a slightly more dense, but on the right side is the very dense breast. And this is not uncommon in young women. And it can have a false negative, meaning there could be a cancer sitting in the middle of that dense breast, and we wouldn't know because it's so hard to see it and distinguish it. So already we have younger women who are getting cancer. We have breasts that look like this because this is more common. And so when we look at this, different reports have suggested as low as a 30 to 45% likelihood of finding a cancer. When we talk about interval cancers, what we mean is from that first year to the next one, a cancer has grown and you can feel it. That's what we want to avoid. We don't want to find cancers when we can feel them. We want to find it before we can feel this. Dense breast tissue alone, in addition to family history, indicates an increased risk of breast cancer. And the reason this makes sense biologically is the more dense your breast tissue is, the more activity your cells have. So every time a cell divides, it has a chance to go awry and not grow. Digital mammography has improved the performance, but not, it's gotten up to as high as 70% in some reports, but we're still not as good as we'd like to be. So again, we go back to this progression of cancer, and I want to speak specifically to the higher risk woman on this. You start with your normal duct, you go to ductal carcinoma in situ, and you go to invasive duct. The problem is that interval from ductal carcinoma in situ to invasive cancer is much shortened. It may be as short as, instead of being years, it could be months that it goes. And so we need to find a tool that's not going to miss any of these. So again, I'm sorry it doesn't project very well, but this is an MRI examination, and as you can see some of the white. I wonder, do these lights up here go down? I wonder if they do at all. Do you think? Because some of these will project better. I don't know. Can you see it a little better then? Okay. So when you look at this, this is this is what's an MRI examination, and the white is the contrast that goes into it. So when you get an MRI, and we'll talk a little bit more about the advantages and disadvantages, you do get contrast associated with. That area on the left side is actually the cancer. It shows up as a big white area on a black background. Continue. So the advantages are, the way that this works is the concept is, it's a functional test, meaning when your cancer starts to grow, if you develop a cancer, you get blood vessels around it. So what we were actually looking at is a picture of the blood vessels. It has relatively less effect of the density, meaning if you have dense breasts, we can sort of subtract that out. Obviously, there's no radiation exposure. It's all magnets that are used. The disadvantages are somewhat obvious, too. It's an invasive test. You have to get an IV for it. So there's no way around that because you need the contrast. It's expensive, and this comes down to what insurance companies will allow and not allow. It's a couple $1,000s, and that's really because the equipment is so expensive, plus the dye is expensive to have. It does have a higher number of false positives. It picks up things that may not be cancer, but you need to. And then the question is always, could there be clinically unimportant areas that we're seeing? Maybe this cancer would never go on. Again, it's that argument of who would progress and who won't. It's very hard to argue against treating a cancer once you found it. So when we look at the limitations of this, one of the big limitations and the reason it hasn't become available areas, the equipment is all different and it's updated continually because it is so computer oriented.